The following podcast is part of a certified educational activity titled Forward Progress in Newly Diagnosed Multiple Myeloma. New Developments with CD38 Antibody Quadruplets. Access the entire activity and complete the post-test at peerview.com/PHX860. Downloadable slides are also available.
Hello, my name is Suzanne Lensch. I'm from Columbia University Irving Medical Center, and I'm pleased to welcome my colleague, Dr. Joshua Richter from the Icahn School of Medicine in Mount Sinai in New York. I would like to welcome you to our Forward Progress in Newly Diagnosed Multiple Myeloma. So in this activity, we will explore the rapid emergence of CD38 quadruplets as an upfront treatment option and share examples from our practice about how new evidence with quads is changing the way we manage patients with multiple myeloma. So let's begin. And let's start with looking into the NCCN guidelines for the primary therapy of stem cell transplant eligible patients. So the preferred regimen for the NCC guidelines is bortezomib, lenalidomide, dexamethasone, or carfilzomib, lenalidomide, dex, all triplets. But there are other recommendations based on large trials such as Griffin, Cassiopeia, and now Perseus. And those recommendations include quadruplets, daratumumab, bortezomib, lenalidomide, and dex, or other useful options like D-RVd, D-VRd, daracyclophosphamide VD, or isatuximab RVD. But how does it look like for patients who are non-transplant candidates? Here again, the preferred regimen is a triplet with dara, len, and dexamethasone. And this is based on the MAIA trial, which established D-RVd triplet as an upfront therapy in transplant ineligible patients. But the guidelines also include quadruplets for non-transplant candidates, and this is based on ALCIAN, which showed that the efficacy of quadruplets, such as dara, Velcade, melphalan, and prednisone, is superior to VMP as a triplet in patients who are not eligible for stem cell transplant. But despite the progress, there's an uneven integration of antibody platforms into multiple myeloma care. And what you can see here are data from the INSIGHT multiple myeloma trial, which was looking for monoclonal antibody use in patients between 2016 and 2021 in the first and second line treatment. And what you see is that the antibody implementation was only 2% in the first line and 14% in the second line treatment. I think that's pretty below what we would expect in the United States, but even if it reflects Europe, it shows that the integration of monoclonal antibody is unexpectedly low. That's why the goal for this activity is to improve your knowledge of the latest clinical trials and real-world evidence supporting CD38-based quadruplets in newly diagnosed multiple myeloma, equip you with the skills you need to recommend CD38-based quads for patients with newly diagnosed multiple myeloma, but also provide you with guidance on practical considerations when using CD38-based platforms in newly diagnosed myeloma, including the dosing and safety. And with this, I would like to ask my colleague, Josh Richter, to give us some new directions with CD38 quads in newly diagnosed multiple myeloma. Josh, take it away.
Thank you so much, Suzanne. So yeah, we've it used to be sequential doublets and then triplets, and now we're in the world of quadruplets. And I think the area where this has been most profound, especially in the US, has been the daratumumab containing quadruplets with regimens such as Griffin and most recently Perseus that was presented at this most recent ASH meeting. So Griffin was our randomized phase 2 study comparing the RVd standard that has been used for many years in transplant-eligible myeloma patients, now compared against the dara-RVd quadruplet. And what we can see here on this slide is that although the response rates are already nearing 100% with RVd, what we gain with the addition of daratumumab is a much deeper response rate profile, more CRs, more MRD negative patients, whether or not you're evaluating at the end of induction, at the end of consolidation, or further along down the maintenance road. And as we know in myeloma, at every step along the way, the deeper responses tend to be more durable. So moving from a triplet to a quad really increases the depth of response. Now, we see this across a variety of studies, and interestingly enough, outside of the US, many countries still use thalidomide as their IMiD of choice up front. And in the Cassiopeia study, which compared the VTD standard for transplant-eligible myeloma patients with D-RVd, they also had a very interesting second randomization. And the data here shows that after patients received autologous transplant in Cassiopeia, they were randomized to either observation or to receive one dose of daratumumab every 8 weeks. And ultimately, this gave us four different cohorts: people who got VTD up front, followed by observation, VTD followed by DARA, or DARA VTD followed by observation versus DARA VTD followed by DARA. And ultimately, what I think my interpretation of this data so far is that a CD38 needs to be part of your upfront therapy approach in one way or another, either as part of induction or as part of maintenance. So far, we're not necessarily seeing improvement in outcomes using both in upfront and in maintenance, induction and in maintenance, actually. But we do know that the one group here that did worse were the patients that neither received it as part of their induction nor as part of their maintenance approach. And now most recently, we saw the phase 3 of the DARA-RVd combination, again, presented recently at ASH. This was the Perseus trial, so randomization of DARA-RVd followed by transplant, more DARA-RVd, and then DARA-REV maintenance versus the VRd standard followed by autograft, more VRd consolidation, and then REV maintenance. And although in the US, we tend not to use a lot of post-transplant consolidation therapy, I do think that the RVd induction still represents the most common induction regimen in the US, and hopefully data like this helps push us more towards the quads as a country. And when we look here in terms of the progression-free survival, what we note again is that because we have a higher incidence of deeper responses, we have more CRs, more MRD negatives, we do see a separation of the curves and an improvement in progression-free survival with DARA-RVd over the RVd group. And this is the 4-year follow-up data. And at 48 months, there was an 84% rate of remission control in the quad compared to only about a 67% in the triplet. So we do recognize that there's an improvement here, at least in progression-free survival. Longer follow-up is going to need to demonstrate overall survival. In terms of safety, the main toxicity that you add when you bring in a CD38 as part of your treatment is increase in upper respiratory tract infections because there's a lot of CD38 expression in the pulmonary vasculature. And because CD38 is expressed on other hematopoietic tissue, there is a higher rate of neutropenia and other cytopenias like thrombocytopenia. Anemia tends not to be as much because you actually get really good disease control, which remember that neutropenia and thrombocytopenia are treatment toxicities. Anemia is both a treatment and a disease toxicity, so better disease control ultimately leads to better hemoglobin control. But again, ultimately, upper respiratory tract infections, cough, and other infections are going to be higher with a CD38-based antibody. And it's important to note that if you have recurrent infections in the setting of hypogammaglobulinemia, these patients may benefit from intravenous immune globulin therapy. The Cepheus trial is an ongoing phase 3 study, which will provide additional data about quads in the upfront setting. Again, these are patients where they are not planned for upfront autograft. So looking at VRd followed by RD long-term, mimicking the SWOG 777 study, comparing this now with the quadruplet of DARA VRd followed by a DARA REV long-term approach. And we're anxiously awaiting the results of this study. The Skylark study was another wonderful study. This was presented recently from Betsy O'Donnell, and this looked at saying, well, if a CD38 quad is going to give us some really great outcomes, what about some of the other CD38s? And in fact, what about other proteasome inhibitors? So as opposed to daratumumab being the CD38 of choice, here we use isatuximab along with a KRD backbone, so carfilzomib instead of bortezomib. This provided once-weekly administration, and again, an extremely efficacious regimen with 100% overall response rate, 88% of patients being VGPR or better, with progression-free survival of 2 years of over 91%, many of these patients achieving MRD negativity. The German correlate of the Griffin study was the GMM-GHD7 study. This is looking at ACA-VRd versus VRd in an upfront transplant-eligible patient population. And again, extremely efficacious regimen here using the isatuximab backbone with higher rates of progression-free survival, higher rates of stringent CR, and the deeper remissions by adding the CD38 to the VRd backbone.
That was really great, very comprehensive overview. And I think we have a lot of support using quadruplets in patients who are fit or transplant eligible. But we shouldn't forget the Alcyon trial. This trial compared Dara, Velcade, Melphalan, prednisone versus VMP alone, a regimen that's not really very often used in the US. We have some concerns to use Melphalan, but I think what it showed really is that the addition of Dara increased the progression-free survival, and the trial has a relatively long follow-up. You can see that 6 years, 72 months, and when we compare the PFS, it's 7% in the VMP arm versus 32% in the patients who received, in addition, Dara. I think pretty convincing to add Dara really to the triplet and give quadruplets also in non-transplant eligible patients. So, but we have another study, the IMROS study, that looked for a quadruplet in non-transplant eligible patients, newly diagnosed, and that trial compared ACA-VRd versus VRd. It's a large clinical trial with almost 500 patients. The primary endpoint was met, showing that the addition of ACA to VRd significantly improves PFS in the transplant-ineligible patients, newly diagnosed. But we don't have really the final data because they will be presented at ESCO. And I think this will be one of the most important studies really to see at ESCO this year. So, but maybe we should switch to really our patients we are treated with quads. And I brought a case presentation from a patient we treated. It's a 64-year-old patient with a past medical history of hypertension, hyperlipidemia, also diabetes mellitus. She was diagnosed with multiple myeloma with a relatively high monoclonal protein of 6.6. Free light chain ratio was 5.78. 24-hour urine normal. She had an IgG lambda monoclonal protein. What's really striking, she had a high infiltration with atypical plasma cells of her bone marrow, 60 to 70%, also some high-risk cytogenetics with translocation 414 and 1q gain. Further workup showed that the beta-2 was 5.4, LDH and albumin was normal. And she was diagnosed with an RISS stage 2, and we started her on Dara-VRd with the intention to really give her 4 cycles of an intensive induction, collect the stem cells, followed by a stem cell transplant. And what you can see is also that the patient had really a very nice response rate. 4 weeks of treatment, her M spike decreased from 7 to 2.3 very nicely. You can see also there was normalization of the light chains. And what is most important, especially when we collect the stem cells, that the percentage of plasma cells in her bone marrow decreased from baseline 70% to 10 to 20% after only 1 cycle. And I think this really reflects that the induction with a quadruplet is very powerful, and many patients go already with a CR into the transplant. But maybe, Josh, you brought us a case from your practice of a patient who is not transplant eligible and received the quad. Maybe you can share, your patient.
Absolutely. So my patient was a little bit older than yours, so 74 years old, and had some medical comorbidities, high blood pressure, some mild COPD, and basically she ultimately was diagnosed because she was following up on regular imaging from a pulmonologist. They saw a shadow in one of her vertebrae. It ended up being a compression fracture, and further workup revealed an IgG kappa myeloma. She actually had also very heavy infiltration in her marrow, 80%, which was giving her a hemoglobin in the 6 range. otherwise not in renal failure, but very high burden disease, an IgG of over 10 grams, light chain over 1,000. And, I always think that for patients who have very, very bulky disease, especially patients for whom I do think it's a bit tougher to get higher doses of lenalidomide into some of the older patients where we're going to have to back off a little on the len, and adding the bortezomib to the D-RVd regimen is not a big ask. We're talking about 3 subcutaneous injections in a month. I frequently opt to give quads up front to some of these patients to more rapidly debulk them. She responded very nicely. And ultimately, what I did for this patient, which I think a lot of us are doing colloquially, is giving them the quad induction, but then I call this Griffamaya, where you give them the Dara-RVd up front and then just Dara-Rev as a long-term maintenance.
And Josh, I completely agree. I think the 25 milligrams Revlimid are very tough on many, many older patients, and bringing it down the Revlimid to 10 milligrams, but combine it with, I don't know, a low level of bortezomib is really much better tolerated. Completely agree. So, but let's see what's the real world evidence with our CD38 antibody quadruplets. And here I want to share a study from Dr. Joseph. So what the team did is they did a real world comparison of D-VRd of patients treated between 2018 and 2022, around over 300 patients. And they compared that with patients who received triplets, over 1,000 patients. And what they showed was very nice. They showed that the real world evidence and principle mirrors what we see in PERSEUS. That means D-VRd induction increases the PFS in both standard and high-risk patients. And the 2-year PFS is 93% in a triplet compared to 98% with a quadruplet D-VRd. But when you look for the 4-year PFS, it's 61% in the triplet versus 85% in the quadruplet. I think really convincing, even in real-world data, that the quadruplets are much more powerful. So but when we treat patients with CD38 monoclonal antibodies, and Dr. Richter mentioned that already, there's an increased risk of infections. And that's why it's important that all those patients receive a prophylaxis. It's a prophylaxis with HSV. And very often patients ask, I'm already vaccinated against zoster. Do I have to take that medication or that prophylaxis? And the answer is yes, you have to. Pre-medication to really for the CD38 infusion-related reactions, Tylenol, Benadryl, dexamethasone. What I have good experience with is really montelukast the evening before. And the first couple of treatments, later you don't have to do that. Don't forget really the blood screening, and also with a type N cross-match, and also hepatitis B screening. That's important. And you need to initiate prophylaxis with entecavir if patients are Hep B poor antibody positive. Very important. I guess a couple of us, made some bad experience by not doing it, and reactivation of hepatitis B. So that's important. Usually we prefer to give the CD38 monoclonal antibodies daratumumab subcutaneously. It's kind of, better tolerated. The observation period is shorter. It's only 3 hours versus 6 hours, for the IV infusion, and the average infusion time is much longer with the dara intravenously. So I think most of us really switch to subcutaneously. And again, Dr. Richter mentioned already, treat infections aggressively. We more and more use IVIG. It is expensive, but I think it's less expensive to treat prophylactically than having patients treated for pneumonia, or even worse, having them admitted to the hospitals with pneumonias. With the real world data, maybe we should go back to our case, the initial case I presented. Remember that was a 64-year-old patient, transplant eligible, with a high level of a monoclonal protein, 6.6, very nice response to 2.3 after only 1 month of treatment. We decided to treat that patients with a quadruplet induction therapy followed by a stem cell transplant, but maybe assume, this is a real world case and the creatinine is not normal, the creatinine is 4, and the patient complains of severe neuropathy. Josh, what would you do with that patient? Still give quads, or how would you approach this patient?
So, the myeloma is never going to be as sensitive as it is right now. So, you always want to strike Well, the iron is hot. So in terms of the Revlimid, we have to remember that it's not so much that you're going to have uh, unknown toxicities with Rev. We know that as your GFR goes down, your ability to clear it goes away. So a patient like this, 25 certainly wouldn't be tolerated. We'd probably have to drop to either 5 or 10 milligrams in order to accommodate the decreased clearance of the lenalidomide. And for patients with severe neuropathy, there are other quads where we can substitute in carfilzomib, and this data has been published from a number of people, including Luciano Costa's master trial and Ola Landgren's Manhattan trial, giving the DARA-KRD quadruplet.
Absolutely. And I think, and especially when you have concerns about high risk, carfilzomib might even be the better choice, and Velcade should be replaced. So, but let's talk about a little bit of MRD and what is the role of CD38 quads achieving MRD negativity. We talk so much about that. Maybe, Josh, you can also share some data on this.
So yeah, I think this is me mentioning Ola Landgren, who's been at the forefront of MRD. So we have to talk about the MRD data here. And one of the things that we've begun to understand about MRD, so minimal residual disease or measurable residual disease, it's our newest and latest, greatest technology of evaluating 1 in a million or 1 in 10 million cancer cells. And we're really using a few different platforms: the next generation flow cytometry, NGF, or the next generation sequencing with the clonoSEQ pathway, NGS, and evaluating at 2 different depths, the 10 to the minus 5 and 10 to the minus 6 levels. And what we can see here, comparing the quadruplet over the triplet, especially at the 10 to the minus 5 sensitivity, is a statistically significant improvement in rates of MRD negativity, from around 47 to over 75% MRD negative at that level using the quad. So again, I think whether or not you're using NGS or NGF, and whether or not you're using a 10 to the minus 5 or 10 to the minus 6 standard, we recognize that the quadruplet is far better at getting those really deep responses below the limit of our current detection. One of the studies we're all anxiously awaiting the results from is the SWOG 1803 study, also known as DRAMATIC. And this is a study looking at the fact that Goldilocks is always the answer, right? We don't want the porridge too hot. We don't want the porridge too cold. So it's not stopping maintenance after 2 or 3 years, because so far from studies like the CTN0702 study, anytime we've done studies to show fixed duration versus continuous maintenance wins out. But that's the porridge too cold. Too hot is, we know that there are probably a subset of patients for whom we could stop and get unnecessary years of therapy, even if it's lenalidomide alone. So trying to get the porridge just right, and Rita Krishnan has the DRAMATIC study, which provides induction therapy. Then patients either receive lenalidomide or daratumumab and lenalidomide as a maintenance therapy, and there are MRD stopping rules along the way. And the hope is that one day soon, we can kind of plug it all in and say, well, you have low risk, you have sustained MRD negativity, you will probably do just as well with without maintenance, and provide not a time stopping rule, but an MRD targeted stopping rule to limit patients' exposure to long-term therapy. And also actually presented as a plenary at the most recent ASH meeting was the ISKIA trial. And although we don't yet have PFS data presented from this study, we have MRD negativity rates comparing the ESA KRD quadruplet versus the KRD triplet in transplant-eligible patients. And what we see from the primary data is that when we evaluate patients either with the 10 to the minus 5 or 10 to the minus 6 standard, we do see higher rates of MRD negativity with the triplet, with the quadruplet over the triplet. And now, one of the things that's really important that Suzanne pointed out is that, especially with high-risk disease, we do feel that at some level, Kyprolis may be a better approach, even though studies like the Endurance trial, which looked in transplant-ineligible patients, didn't really show a global improvement. Some subset analyses later on did show that 1Q gain may benefit from Kyprolis over Velcade. Even the KRD triplet does have very good rates of MRD negativity. So a KRD triplet is not wrong. But again, in the realm of going from a triplet to a quadruplet, we are improving MRD negativity rates. And I think we can all recognize across tumor types, adding classical chemotherapy from a triplet to a quadruplet is a lot. but we very readily, in almost all tumor type now, add a monoclonal antibody to increase response rates, and you're not getting a substantially higher increase in adverse event rates. So it's much more easy to up your regimen from a triplet to a quad simply by adding a monoclonal antibody. And again, when we look at the forest plot across a variety of different cutoffs, again, versus the 10 to the minus 5 or 10 to the minus 6, and especially in the much deeper 10 to the minus 6 category, we do see that across the board, the quadruplet is favored over the triplet. And especially if we look on the right-hand side, the 2 or more high-risk cytogenetic abnormalities, the really, really bad players in myeloma, able to achieve much deeper rates of MRD negativity with the isatuximab-based quadruplet over the triplet. And again, just as what we've seen with the other CD38 trials with daratumumab, like Perseus and Griffin, the main toxicity that you get by adding a CD38 monoclonal antibody is an increase in neutropenia, febrile neutropenia, and upper respiratory tract infections. And again, most of this is generally manageable and with an eye on the immunoglobulin levels for potential need for IVIG for patients who may need it. And Suzanne, why don't you take us home with some conclusions and take-home messages?
Yeah, great data. And I think, we should really conclude and, share our insight. I think there are a lot of trials out that really show that quadruplets, including CD38, as of now, isatuximab, daratumumab, plus an IMiD proteasome inhibitor and steroid, are superior and more effective compared to triplets in patients who are newly diagnosed and should be a standard of care for the fit patients. We have so many data from Cassiopeia, Griffin, Perseus, but also from the GMMG and from the Ischia trial. So I think that most of us, have already, switched to a quadruplet. We talked about stem cell transplant eligible, but I just want to mention that I think we should move a little bit more to fit and unfit patients because the role of transplant is not really quite clear. And I think using the term fit patients would expand the number of patients who could receive quadruplets and would be eligible for this from the beginning. We discussed also a little bit the quads in patients who are unfit or non-transplant eligible. And here we are all waiting for the upcoming IMROS trial that was VRd versus VRd and will be presented at ASCO this year. Alcyon trial, D-VMP, showed really convincing data with a long follow-up that a quad is better than a triplet. And remember, we discussed that you have the potential option of dose reduction in those patients and even better tolerated in older patients. And again, there's an unmet need in the very frail patients and the ultra high-risk patients with more than 2 high-risk cytogenetic markers, which despite CD38 monoclonal antibodies still don't do very well. And with this, I would like to thank you for your attention and thank you, Dr. Richter, for kind of, a great presentation. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/PHX860. This activity is supported by educational grants from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC and Sanofi.